Hi, I'm Lizzie. I'm a physiotherapist for East Coast Community Healthcare, and today we're going to be talking about falls and frailty. So how we can prevent falls and how we identify and manage frailty. So an old definition as to what a fall is, it is an unintentional event that results in a person resting on the ground, and it is not due to an intrinsic event, which we would call a collapse. So that would be when a person might feel dizzy and subsequently fall onto the floor. So the impact of falls can be for the individual. They can lose their confidence and they can become fearful of falling in the future. And that can cause them to become deconditioned and can then increase the likelihood of them falling again. There is also the financial impact of falls. So there are, with fragility fractures, so if you fall and sustain a fracture, it costs the UK £4.4 billion, with hip fractures alone equating to £2.2 billion of this sum. So it's really important for the NHS and also for the individual that we try and prevent our patients from falling. There are also other statistics of falls which are forever changing. So there are 11,000 fatal falls in a hospital environment per year, and 800,000 people are admitted to hospital each year with a fall. There are lots of reasons as to why someone might fall, and we will go through some now. So it can be their medical conditions, whether that's an acute condition, so if they've got an infection and they have become confused and off their legs and they're not very well. But it also can be any chronic medical conditions. So for example, if you've got a neurological condition like Parkinson's disease, or you've had a stroke, that can cause you to be imbalanced. You can have particular weakness which can cause you to fall. And you've got other various medical conditions, so cardiovascularly, if you've got a respiratory condition or a cardiac condition, that can cause you to be breathless, and you might overexert yourself and fatigue and subsequently fall. But that's quite a never-ending list. In terms of medication, if we are on 4 or more different medications, then we are more likely to fall. Those which particularly depress the central nervous system, so your opioids, your antipsychotics, your diuretics, and your sedatives, particularly do increase the likelihood of you falling. And that's why we recommend, if you are on long-term medication, that you have an annual review to make sure that that is still appropriate and it's the right dose for them. Also, we want the person to know what they're taking and why they're taking it, and that they're managing it correctly. Our sensory system is really important. This is controlled by our eyes, our ears, and our brain. And these naturally deteriorate as we get older. So we want to make sure that our patients keep good check of their eyes and their ears, and if they're appropriate for balance exercises, then that would also be beneficial. We've then got the psychological and cognitive factors. So again, that can be acutely. So if someone is confused or delirious, then they can be at an increased chance of falling. But it can be chronic conditions. So if you've got a cognitive impairment, then that also increases the likelihood. Also, how that person is with their mood and their motivation as mentioned previously, if they're quite fearful of falling, then that can be quite a spiral of deconditioning and putting off the activity and causing them to fall. We've then got the environment, so we need to make sure that wherever they reside, that it's safe for them. So removing any hazards, if that's furniture or wires, rugs, mats, considering pets as well, how they could be potential trip hazards, and making sure that it's just clear of any clutter so they can safely mobilise and function in their home environment. And then life choices. So again, this is acute or chronic use of alcohol or illicit drugs, that we would recommend that these are not used ideally. Further reasons for falls can be whether we are eating and drinking enough. So making sure that we are well hydrated. If we are dehydrated, then we might feel unwell and dizzy, our blood pressure can lower and we might fall. Likewise, if we're not eating enough, we're not getting enough calories or energy, then we would also feel unwell and we could be falling. So it's important that we make sure that our patients have got access to food and drink, and if they physically can't get it themselves, then providing that for them. And the person's mobility, so we need to look at how they mobilise, how steady they are, how safe they are at walking, looking at their walking aids, if that's appropriate for them, or whether they need to have a different walking aid which will give them more support, and making sure that the walking aid is in good order, so it's got good the ferrules at the bottom of the frame or the stick, and it's the right height for them. Other reasons for falls can be our feet, so as well as our footwear. We need to make sure that we keep good condition of our feet, so cutting our toenails and addressing any problems early on. So if you have a bunion, getting that treated, for example. And then our footwear, so making sure that we wear well-supported footwear which have got a good grip to them, and it's a fully encased shoe, so we don't want anyone wearing sandals or a heeled shoe, which would be inappropriate and could increase the likelihood of them falling. We've then also got continence, so we often see people rushing to get to the toilet in time, so we want to look at how well they can control their bladder. Are they appropriate to be referred on to the continence team? Do they need some products to give them some reassurance if they can't get there in time? We then look at their fluid intake. Are they drinking too late at night? Should they be going to the toilet earlier before they go to bed? And if they are not able to get to the toilet in time, then we would consider offering a urine bottle to men, or placing a commode beside the bed, so they are reassured that they don't have to rush to get to the toilet in time, and hopefully reducing the likelihood of them falling. So the main thing with all these risk factors is prevention as best as we can. Falls can't be eradicated, but it should be everyone's business to try and prevent the likelihood as far as we can. Frailty and falls are interlinked with each other. So if we fall, then that can escalate our degree of frailty. And so if we can manage one well, then hopefully the other should also improve. So there is a association when we say someone is frail, that they are an older person, and that is definitely not the case. It is not an inevitable part of ageing. So we can see, we might associate frailty with the lady in the wheelchair who is underweight, maybe wheelchair bound, looking quite sorrow, whereas actually someone of the same age as her could be the person on the left who's running and is very active and fit for the same age. So frailty is a progressive long-term condition characterised by physical and or cognitive resilience. So if you are frail, unfortunately you are 4 times more likely to be admitted into hospital, admitted into a care home, or dying. And it's important that we identify frailty in order to reduce the likelihood of unnecessary admissions to hospital. So it is an increased vulnerability in bouncing back. And that can be from a minor illness or injury, where they will recover from that, but they don't return back to their previous selves 100%. And that can be quite a trajectory of decline unless we manage it early and manage it well. So that is why early identification is really important and should form part of any health or social care interaction. What is it like for a person living with frailty? They often report fatigue, reduced muscle strength, and unintentional weight loss. And as you can see, that can lead to them falling. That could mean that they are admitted into hospital. In hospital, they can become deconditioned. It can cause further disability and can affect their ability to perform activities of daily living. And it can also lead to a lower life expectancy. How might the person present to you? So there's a few examples here. They might have reduced mobility, they might be falling, they might report a change in their mood and their cognition, and they will have difficulty performing personal and domestic activities. So whether it's one of these or a multiple of these symptoms, it will have an impact upon that person's quality of life and also their length of life. So in terms of how we can identify frailty, there are different identification tools available, but for today we'll be focusing upon the Electronic Frailty Index and the Clinical Frailty Score or Scale, which is also called the Rockwood. So the Electronic Frailty Index is an automated identification tool used predominantly in primary care. This is where if you were to go to your GP and you were to report certain symptoms and be diagnosed with certain conditions, these collate and will classify you as being either mildly, moderately or severely frail. So these are the deficits which link in with the Electronic Frailty Index. So for example, if you were to have one disease of arthritis and one symptom of having had a fall, then that might classify you lower down on the scale, and that would be more than mildly frail. Whereas if you've got a higher number of these issues, then you'll be classified as more moderately or severely frail. So we can see here that classifying these patients as being mildly, moderately or severely frail links into their life expectancy. So for those who are severely frail, they do have a lower life expectancy, and we want to change this. We want to, with good management, improve their life expectancy and their quality of life. The Rockwood or the clinical frailty score is used acutely and in the community, and this is where anyone who's appropriately trained can complete. It needs to be completed 2 weeks prior to you seeing that person, and that's because when you are seeing them, they might be in a period of being quite unwell and not their true selves. So do make sure that it's backdated to 2 weeks prior, and do talk to the family, friends, carers, as they know that person best, and you are only seeing them as a one-off opportunity. So you want to be as accurate as possible with your scoring. So it is a scale from 1 through to 9, and there are descriptions as to help you classify that person. So 1 being very fit, so that tends to be the fittest for their age group, all the way through to 9, where that person is terminally ill and is expected to have a life expectancy less than 6 months. So it's really important that we use the descriptors as well as talking to the patient, their family and friends, to make sure it's an accurate choice or accurate selection. So once we have identified the patients who are frail, the best way to manage it is by completing a comprehensive geriatric assessment. So this needs to be completed by an appropriately trained healthcare professional. And it's got very good research that by completing one of these plans, the individual is 12 times more likely to be living in their own home or where they prefer to live 6 months after the completion date. So with a comprehensive geriatric assessment, I like to consider it that person's care plan and a document for them to keep. It's where you gather all the information about them, so everything from their medical history to their social support, being really holistic and considering a biopsychosocial approach. It's important once we identify that person's goals that we collaborate as a multidisciplinary team and we decide who's best to provide what intervention for them. And this requires collaboration between the healthcare professionals, but most importantly, the patient. It needs to be important and significant for them, but also using any social support they have. And the expectation is that this document is owned by the patient and the family, and it needs to be regularly reviewed and updated. There are nice guidelines on what to do for a falls assessment. So this entails looking at their falls history, looking at their gait, balance and mobility, looking at their risk of having osteoporosis, and if they are at risk, getting that treated as soon as possible or on treatment. Considering their sensory systems, so if they've got a visual impairment, recommending that they have their eyes tested and any eye conditions treated if possible. So for example, that could be a cataract being removed, but the sensory system also includes our ears, so making sure that our ears are clear, and if we do have hearing difficulty, then recommending that they have a hearing aid. We would consider their continence, any hazards between the home, and as already said, looking at their medication and making sure that that's still correct for them. So it is individualised, it's what matters to that person. So make sure that their goals are important for them, and that they are achievable, realistic, and you set a time for when you want them to be achieved by. As mentioned, do involve carers and loved ones with this. It's also important that we educate the patient and the family on what we mean by frailty, and trying to be positive with what it means and how we're able to help. In terms of what we can provide, there are different interventions. If appropriate, we can provide that person with strength and balance exercises. So we would request that a physiotherapist assesses them and prescribes them an appropriate level of exercises for them. It can be nutritional support, so we can give them advice ourselves, or if we want extra support, then asking a dietitian for more advice. It can be looking at their medication, adjusting their lifestyle, so if they are having difficulties in certain activities, looking at adjusting those to make it as easy and safe for them as possible, and to try and avoid fatigue and the chance of them falling or suffering an injury. Our occupational therapists can provide equipment or adaptations in the home, again to make it as easy and safe for that person to live, and also for maintaining their independence. Other treatment, we try and build someone's confidence up. As mentioned, if a person were to fall, then they can become fearful of it happening again. So the sooner we can re-engage them into activities and practice, then that will hopefully improve their confidence. It's everyone's responsibility to try and manage their frailty, try and reduce the trajectory of decline, and improve their quality of life. We look at social care, so if they need some extra support, looking at what services are available to help them with that. And we also consider, if they are nearing the end of their life, what their wishes are. So where do they want to be, who do they want to be with, and having those discussions early is very important. In terms of some resources, there is a lot available. We like to, if someone is falling, we do recommend creating a falls diary. So this is where the person or the family will record the dates in which they have fallen, the details of the fall, so what time it happened, what were they doing at the time, can we identify what was the cause, and if there's a pattern of their falls. If we are able to identify why they have fallen, then can we do anything to try and prevent further falls by addressing that issue. We've also got backward chaining, which is a technique where if someone has fallen and they aren't able to get themselves up, then we teach them how to safely do so. We make sure that we only go through this technique if we feel that individual is able to follow instructions and has good range of movement and strength to give it a try. We can also run through this technique with any family or friends. So by doing this, it means that they're going to get up off the floor sooner, and also reduce the likelihood of having to call an ambulance or another service out to try and get them up. The I Stumble resource is a step-by-step guide for when someone has fallen, what to be looking out for, and what steps to take to whether you need to call an ambulance or call the GP, or whether you're able to get them up yourself. And this is commonly used within care homes. And then there are additional resources on preventing falls on the final resource there.
Our question from providers for this session is, what strategies and exercises could be used to improve coordination for those with dementia in order to limit falls and increase activity?
So I think it depends upon the degree of their dementia, so whether that's mild or quite advanced. I personally would recommend quite a functional approach, so completing activities of daily living, so things like getting washed and dressed. So getting washed, it requires coordination, whether that's actually having a shower or a bath or just having a strip wash. They're having to maintain their independence, but also work on their coordination with the wash itself and getting dressed, where you then need fine motor skills with doing buttons up, adjusting clothes, but also that would be if they're quite advanced in their dementia. If they've got quite mild dementia, then more activities or exercises which they enjoy. So it's got to be meaningful for them to engage with. Then if you were to select a different exercise which they don't really enjoy, then they're not going to engage, they're not going to practice it regularly.
Thank you for watching. If you would like more information, please visit norfolk-and-suffolk-caresupport.co.uk, where you'll find further training on our learning portal. The link for this website is in the description down below.